pulmonary arterial pressure. The amount of pressure inside the pulmonary artery. Okay? And we already know what the normal value is. It's 25/10. So we'll look at it more in detail. So here are the learning objectives. After this lecture, you will understand the indication for PAP monitoring. Know the normal values for PAP, right atrial pressure, and waist pressure. Know the formula used to calculate pulmonary vascular resistance and systemic vascular resistance. Know the conditions that will cause PAP pressure to increase or decrease. Know the conditions that will cause RAP and RVP to increase or decrease. Know the conditions that will cause the waist pressure to increase or decrease. Okay, so in order to monitor the PAP pressure, you have to put in a swan-Ganz catheter. Okay. Now remember, we have a CVP line. The CVP line is a line that just monitors the CVP. And CVP approximates right atrial pressure. Okay, so if I want to know what my right atrial pressure is, I can look at my CVP. Okay, but that's not the case with the PAP. So in order to measure PAP pressure and the waist pressure, you're going to have a swan-Ganz catheter. Okay, so the pulmonary arterial catheter. Okay? Normal value for the pressure inside the pulmonary artery is 25/10. Now, I've told you this before. Please don't be very rigid with the normal value on the exam, okay? Because the textbooks are different. So now, if I say, well, 25/8, that would be normal PAP. If I say 26/12, well, that's about normal, okay? If I say 27/9, that will be about normal. But I would have problem if you gave me 40/20, okay? So that's the way you should be reading your normal value, okay? So the numbers we're giving to you are reference numbers. What is about normal? So anytime you see a number that is 1, 2, or 3 points above or below what you know to be normal, please don't react to it. Just call it normal value. Okay? I want you to know that. Indications for PAP monitoring. Assessment of cardiovascular function. Shock of all types. Assessment of pulmonary status. Assessment of fluid requirements, preoperative monitoring, therapeutic indications and diagnostic indications, patients with severe coagulation defects and thrombolytic therapy, prosthetic right heart valve, endocardial pacemaker, okay? Patients with severe valvular disease, patients with severe pulmonary hypertension, and patients with a significant immune system deficiency. So any one of these here will require the insertion of pulmonary arterial catheter. The bottom line is monitoring pressure. If you're going to monitor the hemodynamic pressures, then you're better off inserting a pulmonary arterial catheter. Parameters measured with the pulmonary arterial catheter, the swan-Ganz catheter. Like I said yesterday, you can measure your right atrial pressure because the catheter goes through the right atrium, okay? And the proximal port opens up in the right atrium. So we can measure the pressure in there through that port. Right ventricular pressure, yeah, we can measure that as well, okay, because the catheter goes right through it. Okay. Pulmonary Artery pressure, yeah. Well, the destination of the Swan-Ganz catheter is the pulmonary artery. So that's where the catheter lodges, So we can measure the pressure in the through the distal port. Pulmonary capillary wedge pressure, well, that's the pressure that monitors the function of the left heart. Unfortunately, the catheter does not go all the way to the left side of the heart, but in order to measure the wedge pressure, we're going to have to blow up the balloon. Okay, we'll blow up the balloon and it blocks the blood flow behind it, and then the pressure being sensed will be pressure coming from the left side. So that's where we'll measure the wedge pressure. So let's review the right atrial pressure now. Normal right atrial pressure is 2 to 6 millimeters of mercury. Measured from the proximal port of the Swan-Ganz catheter. Represents the preload of the right heart. Okay, so now, if you saw on the exam, how do you measure the preload of the right heart? You say right atrial pressure or CVP. How would you measure the right heart filling pressure? The underlying word there is right. Right heart filling pressure, CVP or right atrial pressure. Okay? So anything right is CVP or right atrial pressure. Okay? Determinants of right atrial pressure. What will cause the right atrial pressure to change? Intravascular volume. Yes. The more volume that you have, the higher your right atrial pressure will be. The lower the volume, the lower the right atrial pressure. So that means then that if we have increased venous return, right atrial pressure will go up because the volume returning is very high. If we have a decrease in venous return, then the right atrial pressure will go down. Okay? If somebody is dehydrated, then the right atrial pressure will go down. If somebody is bleeding out, GI bleed, the right atrial pressure will go down because they're losing volume. Okay? When we put volume in people, we do it on the right side of the heart. Okay? All right. So tricuspid valve function, that also affects the right atrial pressure. Okay, so here is the tricuspid valve here. Okay? If the valve is stenotic, meaning that it's very rigid, it's not opening up wide open. So what you get there is blood from here cannot flow in here very easily because it's not completely opened up. So what you have is the pressure here will go up because you have blood here still returning in here that is not moving here very freely. So always you use volume to build pressure, always. If your volume goes up, pressure goes up. If pressure goes down, volume goes down, pressure goes down. On anything, including mechanical ventilation. Okay? So now, so that will cause the pressure here to go up. Okay? On the other hand, if you have tricuspid valve regurgitation, meaning that during contraction of the ventricle, the valve did not close very well, didn't line up very well. When the pressure here goes up, it will push some of the volume in here back into the right atrium. So you got more volume there now, pressure is going up. Okay, so the condition of the tricuspid valve will determine the amount of right atrial pressure. Right ventricular function, that is true. Okay, right here. This is the right ventricle. The right ventricle is supposed to contract and eject blood through the pulmonary valve into the pulmonary artery. Well, if something is wrong in front of it, let's say that I have a tumor here, and of course that is resistance, okay? And because of that resistance, this guy here will not be able to pump blood the way it's supposed to pump out blood. The result of that is that the volume backs up here, and eventually it backs up here. Okay, so your RAP will go up. Or maybe you have the pulmonary valve that is not opening up really well, or even regurgitation of the pulmonary valve, that will cause volume to come back here. And then it backs up into the right atrium. Okay? Indirectly, pulmonary vascular condition. Yeah, that's right, the pulmonary blood vessels.
Hi, are you all familiar with Andrew?
Yeah, remember when I told you, please help me fill up the class. Recommend somebody to the program. There's nothing wrong with the program, honestly. This is a very good program, you know? All right, now let's continue here. Pulmonary vascular condition. Anything that is going on inside the pulmonary system, like if you have pulmonary embolism, pulmonary edema, all of that will create high pressure inside the pulmonary system, like inside the lungs, which then that pressure backs up into the pulmonary artery. Okay? So anytime you have pulmonary edema or pulmonary embolism, blood will not go through the lungs very smoothly because of the resistance there. Okay? All right, left heart function. Okay. Well, if something is going on in the left heart, before it begins to affect the right heart, it will be a long time. I mean, it has to be something chronic. Because now what you get is, now let's say that the aortic valve is stenotic. Okay, it's not very flexible. So blood backs up in here first. It backs up into the left atrium. It backs up into the pulmonary vein. It backs up into the lungs. By the way, that's cardiac-induced pulmonary edema there. It backs up into the pulmonary artery. It backs up here, and then finally backs up here. So it takes a long time. It's got to be something very, very chronic. Okay? You know, we have two types of pulmonary edema. Okay, we have what they call the cardiac-induced pulmonary edema. And then we have non-cardiac-induced pulmonary edema. Now, cardiac-induced pulmonary edema is like you have CHF. Okay? The left heart is very weak. It's not moving the blood forward. And then the blood volume begins to back up and backs all the way into the lungs. So that's cardiac-induced pulmonary edema. Non-cardiac-induced is when it's coming from here, and for some reason it's not going through the lungs very fast, and then you have accumulation of fluid there. Okay? So when you have cardiac-induced pulmonary edema, your waist pressure will be high because it's on the left side. Okay, that's the way to distinguish between cardiac and non-cardiac induced pulmonary edema. The waist pressure will be high for cardiac induced, whereas the waist pressure will be normal for non-cardiac induced pulmonary edema. All right? Causes of elevation in right atrial pressure. What conditions will cause the right atrial pressure to go up? Right ventricular failure. Right ventricular failure, right here. Now, failure means weak. Okay, that's all it means. It means failure means it's not strong enough to move the volume. Okay? So it's not like your heart is going to stop. Okay, if your heart stops, we'll call that cardiac arrest, you know. But failure means that it's weak, or it's failing, it's weak. Okay, so like I said now, think about it this way. The right ventricle is failing, meaning that it's not able to move the entire blood up front. You have volume building up here, and finally it backs up here, and then your RAP goes up. Okay, that's one thing with hemodynamic. as long as there is no obstruction in the system, in the circulatory system, blood is supposed to flow unimpeded from right to left, for 100 years, right? But now, as soon as you have problem in the circulatory system, let's say I have tumor here that is causing resistance for the right ventricle to move blood. What will happen then is that all the pressures behind the obstruction will go up. And all the pressures in front of the obstruction will go down. Okay, because now, if I have that tumor here, I don't have as much volume going around it, and I need volume to build the pressure. Okay? Whereas back behind it, the volume is backing up, so I have more volume here behind it. So that's the way I want you to visualize this. Anytime you have problem in the circulatory system, all the pressures behind it will go up, and all the pressures in front of it will go down. Another way to look at it is, let's say now that Kiera is coming to school, you dressed up, you're going to come to Pima. On I-40, there is a wreck, right? Now, when you get to where the wreck is, you can go across the wreck, right? What happens? Cars will back up. You have cars lining back up. And then in front of the wreck, there's nothing. There's no car going around, right? So now, when cars are backing up, that's pressure going up. Okay, people get angry. Oh, please move, go, move. You know, people get angry, you know. I'm tired of sitting here. So that's another way to look at hemodynamics. Okay? So tricuspid valve stenosis or regurgitation. Right here, and this is very rigid. It's not opening up the way it's supposed to open up. And then volume backs up here because it's still coming, it's still returning from the great vein. When you have regurgitation, that means that the valve, we'll call that incompetent valve. When the valve doesn't line up really good during contraction, what we call that is incompetent valve. So regurgitation occurs because you have incompetent valve. Okay? So again, that will cause your RAP to go up. Volume overload. We're putting volume on the right side, and we've opened up the IV, and it's running in very fast. And then you overload your patient. Okay, that will cause the CVP or the RAP to go up. So that's why we have to have that Swan-Ganz catheter, okay, or the CVP when they're receiving fluid. Because you're going to look on the monitor, as soon as your CVP pressure is above 20. Okay, now, normal is 2 to 6, 20 or less is acceptable. Okay, so if it goes above 20, then that means that you're putting too much volume in, or you're putting it in very fast. You got to back up. Right ventricular failure. Yeah, that's correct. This is failing. It's weak. It can move volume up front, and it backs up in here. Pulmonary hypertension. Well, that's the pressure in here. Pulmonary hypertension means that the pressure is greater than 25/10. The pulmonary pressure is greater than 25/10. That's what we call hypertension. Well, what is causing the hypertension? Well, out here in the lungs, maybe you have pulmonary embolism. When you have pulmonary embolism, your oxygen goes down, right? Your oxygen goes down, and then you breathe very fast, okay, to compensate for the hypoxemia. Now, low level of oxygen constricts the pulmonary vessel, because oxygen is a vasodilator. So if you have low level of it, your pulmonary vasculature will begin to constrict. And when they constrict, that's high resistance. And high resistance means high pressure. So all of that resistance will back up into the pulmonary artery, okay, making it tough for this guy here to move the blood up front. Okay, the right ventricle has to actually stretch to move the blood into the pulmonary artery. And the blood is backing up because it's not going very fast. And then it backs up in here, okay? Cardiac tamponade, I think I explained this before. Now, cardiac tamponade is when you have a pressure level around the heart that is greater than what the heart needs to pump out with. For instance, in the right ventricle, when the right ventricle is contracting, the pressure in there is 25/10, right? So, if a patient has had pneumothorax, okay, or maybe, well, I should say barotrauma, they've had barotrauma, and air is now leaking around the heart, that builds pressure that is greater than 25. Let's say the pressure around the heart now, the right heart is 30, okay? Well, what you see here is 25. Well, because you have pressure around it that is 30, it will be very difficult for it to pump against that pressure. That's tamponade. Cardiac tamponade would always result in low cardiac outputs because it's harder for that chamber to move. On the left side, it's 120/0 when it's contracting. So if we have fluid or air around the heart that is building pressure that is greater than 120, then we have tamponade of the left heart, which would then decrease cardiac outputs. Okay? Any questions about that? So when I have tamponade of the right heart, that means that this guy cannot pump the blood like he's supposed to pump it because it's pumping against a higher resistance. And it backs up in here, and then it backs up in here. Okay, the right atrial pressure goes up. Any questions about that? Causes of decreased RAP. If you don't remember anything else, just remember hypovolemia.
Is that really it?
Yeah.
Is that really it? Hypovolemia is the only thing that would cause it to go down?
Yeah, just about it. Either way you go, if you're bleeding out, that's it. If your venous return is low, the same thing that goes to the volume. Okay. If you're dehydrated, you have hypovolemia. Okay, so all of that, just call it hypovolemia. Okay? Now, how do you treat hypovolemia? If somebody comes in dehydrated, okay, what can we do to increase the amount of volume that is in them?
Give them fluids?
You give them fluid, right? Yeah, you give them fluid. That's all you can do. Okay, you give them fluid first to increase their blood pressure. And then, if their hemoglobin is low, then you give them PAP red blood cells. Because the volume sometimes will dilute the blood cells. Okay, so volume to increase pressure, and then they have lab CBC, and their red cells are low. Then you give them PAP red blood cells. Okay. Okay, right ventricular pressure now. So we're done with the right atrial pressure. When the right ventricle is contracting, you have 25/0 in there. When the pulmonary valve opens up and blood rushes out, then you have your button number. Okay. Now, did I tell you how we get the button number? Did I tell you that? So this is the way you get your button number, your diastolic pressure. Okay. So now let's say that when this guy here pumps out, pressure rises to 25, this valve opens up, and then the blood rushes out. Okay. So as the blood is going towards the pulmonary system like that, the pressure behind the blood will decrease. Okay. As the blood is going down the line, the pressure behind it decreases. Now, when the pressure decreases to below the pressure in here, this valve here now will close. Whatever volume that did not get pumped out from here will build up your diastolic pressure. Okay? So, in other words, there's no way you're going to empty completely what the chamber got filled up with. It doesn't happen that way. So that's why we say that the ejection fraction is never 100%. If you can eject 64 to 75% of the volume that the chamber got filled up with, that's normal heart function. Okay, so whatever that is left there builds your pressure. Okay? All right. So let's go back here. Okay, so we get that. Okay, things that will affect right ventricular pressure. Right heart preload. Now, preload is the amount of volume or pressure inside the ventricle before contractions. Okay? So now, if I have more volume here, I have more venous return from here to here, and then everything pours from here to here, and I have more volume here before systole, that's high preload. Okay? That will cause the right ventricular pressure to go up. If I don't have enough volume in there, then the right ventricular pressure will go down. Okay, just remember that volume and pressure are directly related. The higher the volume, the higher the pressure, the lower the volume, the lower the pressure. And anything, anywhere you go. Okay? The next thing is right heart after load. Right heart after load. Well, after load is the resistance that the right ventricle has to work against in order to eject blood into the pulmonary artery. Well, if I have some kind of resistance here, tumor, hypoxemia, constriction of the pulmonary artery, okay, that's increased after load. Okay, so that will cause the pressure here to go up because now you have more volume sitting here that can go forward because of the obstruction or resistance. Any questions about that? You gotta figure this because eventually we're gonna go to numbers. You know, we're gonna use numbers to represent what I'm telling you now. That's called hemodynamic profile. So on the exam, they say, well, CVP is this, PAP is this, waist pressure is this, cardiac output is this. What kind of problem is the patient having? And what can you do about it? It's called hemodynamic profile. So that's what we're going to do at the end of the lecture. Okay? All right, so we have myocardial contractility. Myocardial contractility. The stronger the contractile force of the heart, okay, the more pressure in there. Okay? The weaker the contractility of the heart, the lower the pressure. Okay? The way, or something we call the isometric contraction. Isometric. Contraction. That's the way the heart contracts. You know, once at the end of diastole, the chamber will contract inwards, pound on the blood like this, coming in like that, pushing on the blood. As it does that, the pressure goes up. And when the pressure in there is greater than the pressure in here, the valve opens up and blood like that, without that wave. Okay? So let's review now. What is normal value for PAP pressure?
25.
Hmm?
Yeah.
Very good, 25/10, very good. Name 3 hemodynamic pressures that can be measured using the pulmonary arterial pressure. Arterial catheter, sorry. What are the 3 hemodynamic pressures that can be used?
Right atrial pressure,
Right atrial pressure,
right ventricular pressure,
right ventricular
and
pressure.
pulmonary artery pressure.
Yeah, and PAP. Okay? Name one condition that will cause right atrial pressure to increase and one condition that will cause it to decrease. Hypovolemia. Hypervolemia can cause it to go up, too much volume. How would you treat somebody, or what would you give to somebody that has hypervolemia, fluid overload?
License.
Yeah, you diurese the patient. So when they have hypervolemia, you diurese them. When they have hypovolemia, you give them fluid. Okay. What is preload?
The
The
amount.
amount of volume inside the ventricle before contraction. Okay? The amount of volume inside the ventricle before contraction. What is afterload? Resistance. The resistance that the chamber has to work against in order to eject the blood out. And so the word afterload means resistance, period. So we have resistance of the left heart, which we call the systemic vascular resistance, and then we have the resistance of the right heart, which we call the pulmonary vascular resistance. Okay? What is that?
We're getting all the visits today.
Hi, guys.
Another instructor. Okay, causes of elevation in RVP. What conditions will cause it to increase? Chronic congestive heart failure. The left heart is very weak and consequently is not moving blood into the aorta. Blood begins to back up. Backs up in here, backs up in the pulmonary vein, backs up in the lungs, backs up into the pulmonary aorta, and finally backs up in here. Okay, like I told you, as long as you don't have any obstruction in the circulatory system, we're good. But the moment you have problem anywhere, then all the pressures behind it will go up and all the pressures in front of it will go down. Okay? Pulmonary disease, yeah. Pulmonary embolism, pulmonary edema, okay? Will back up, okay? And affect it. Mitral valve stenosis or insufficiency, well, here is mitral valve. Another name for that is bicuspid valve. When they want to be funny on the board exam, they call it the mitral valve. Because, a lot of people know bicuspid valve, they don't know what mitral valve is. The patient had just returned from surgery where they had their mitral valve replaced. And you go, well, mitral valve. I don't think Dr. O said anything about that. Well, I'm telling you now, it's something. Bicuspid valve. Ventricular septal defect. Now, ventricular septal defect, if you remember from the baby class, is a hole between the two ventricles. A little hole, tiny hole there. Where normally, the pressure inside the left heart is greater than the pressure inside the left heart. Remember that it's 120/0 here and 25/0. So all that pressure here is pushing the blood in here, some of the blood in here, through that hole, and then it comes back in, into the right atrium. And of course you have more volume now, so pressure should go up. Pulmonary valve stenosis, the same thing. It's very rigid, so you don't have a lot of volume going through it, and then we still got some volume coming down here. So it will build up here and increase the pressure. Causes of decreased right ventricular pressure. Ischemic disease. Now, ischemia is deprivation of oxygen to the cardiac tissue. That's all it means. The cardiac tissue is not getting adequate oxygen, oxygenated blood. Okay, usually, when you look at your EKG tracing, you're going to see inverted T wave. Okay? We we have three eyes in MI. Okay, that's what we said. There are three eyes in MI, heart attack. This is ischemia. The cardiac tissue is not getting adequate oxygen. And then the heart is warning you. Yeah, you look at the EKG reading, you have inverted T wave. That's the heart warning you that I don't have adequate oxygen. Please give me some oxygen. And then you ignore the heart, and then it goes to the second eye of MI, which is injury, myocardial injury. The heart is still warning you. And then on this one here, you're going to have elevated ST segments. And then you're still not giving the heart enough oxygen. Then it goes to the last phase, which is infarction. Now, infarction means that you have scar tissue. You don't have scar tissue as a result of that. And anytime you have scar tissues, okay, in your heart, you lose elasticity or contractile force. Okay, contractile force will be diminished. Well, if it's affecting your cardiac fibers, then that means that your contractile force to move the blood out will be very, very weak. And you will never get it back. Okay? Once you have infarction, that's permanent damage. From there moving forward, your cardiac function will begin to deteriorate. You don't get it back.
Is that why people who have a history of like heart injury or infarction or scar tissue, they're on like blood pressure meds to lower their blood pressure and make that easier?
Yeah, that's it. Because now you lose the contractile force, and your cardiac output is low, as well as your blood pressure. So you're either going to be taking medication that will increase your cardiac output and increase your blood pressure. Okay? And then we have myopathies as a cardiac diseases that affect the myocardium. It's the myocardium. This is the most important area of the heart. We're always trying to protect the muscle. Okay, we want to protect the muscle. And then the endocardium too we want to protect, because the endocardium gives rise to most of the internal structures of the heart. If anything happens to them, then something's going to happen to this. Okay? In cardiovascular medicine, time is muscle. Have you heard that before? I think I've said it before. That's why when somebody is having a heart attack, it's an emergency, because we're trying to prevent them from getting there. Because we know that once they get here, any damage that is done is permanent. Okay? It's permanent. Oh, I think I missed something. We have hypovolemia. Hypovolemia will cause it to go down as well, because you don't have as much volume. And let me go back to ischemia. Every muscle in the heart needs oxygen to work with, period. So if you're hypoxemic in your muscle, in your heart muscles, it will not contract more effectively. Okay? It will not contract more effectively. And then we have pulmonary artery pressure now. Okay? We have the mean, how to calculate the mean. Okay? You're going to do systolic, which is a 25, plus 2 times the diastolic, which is 2 times 10, divided by 3. Okay, so if you did normal plus normal equals normal, well, normal PAP pressure is 25 over 10. So if I want to know the normal mean arterial pressure, Well, I'm gonna do 25 plus 2 times 10 divided by 3, and that will give me 15. So 15 millimeter of mercury. Well, unfortunately, everybody cannot be 15, exactly 15. So we have a range. And that range is usually 13 to 17 millimeter of mercury. That's the normal range for mean pulmonary arterial pressure. Okay, so now this is measured through the distal port of the Swan-Ganz catheter. That's how we measure the PAP pressure. Things that can affect the PAP pressure. Right ventricular function. Okay, now, look. This is not working very well. It's weak. If it is weak, it means that it won't be able to pump out a lot of volume in here. Okay? So if I have less volume, my pressure will be low. Because you see, I need volume to build the pressure. So the pressure will be low here because this guy is not moving pressure in there, moving volume in there. Well, if it's moving a lot of volume in there, well, the pressure is going to go up because that's more volume. That is very easy to know. For instance, if you say that somebody has right heart failure, they have right heart failure. This guy is weak. He's not moving blood up front. Blood is backing up here. Your CVP will go up because it's backing up. Okay? And then because the volume is not being pumped forward, your PAP will be low or even normal based on the degree of the failure. Okay? So, and then your wedge pressure should be normal. So look at this. I'll give you an example now. So I go like CVP 20. Let's make it 20. PAP is 22 over 10. Wedge pressure is 4, and then cardiac output is 4. Let me give you something like this, and they say, what is the condition here? What's wrong with this patient here? And then you go, well, CVP is very high. So that means that the left heart is not moving volume, so it's backing up here and here, so CVP is high. Well, PAP is on the low side because this guy is failing, is not pumping blood into the pulmonary artery, so therefore the pressure is on the low side. The wedge pressure is normal, but it's very low. So any right-sided problem or problem inside the pulmonary system, the heart makes up for it. The cardiac output is never decreased because you have other things like increase in SVR. Okay, anytime your blood pressure goes down, one of the ways that we try to fix it is that your systemic vessels will begin to constrict, or maybe your heart rate would increase to try to make up for the cardiac output. So, right-sided problems and pulmonary problems do not affect the cardiac output. You're going to have normal cardiac output. Okay? But if you have a left-sided problem, then your cardiac output will be low. Okay? The body doesn't make up for that very quick enough. Okay? So eventually we're going to be doing things like that. So this is normal, but on the low side, and cardiac output will be normal as well because of increase in SVR. The body just does it. Okay? Blood volume, we talked about that. The more volume, the higher the pressure, the lower the volume, the lower the pressure. Anatomic and physiologic condition of the pulmonary vasculature, that is true. If we have resistance in the pulmonary vasculature, that affects the PAP pressure. If you don't have enough resistance, that affects it too. Left heart function, that's true. It has to be something that will back all the way up here to affect it. Okay? All right, so here is that carotid notch, meaning that you cannulated an artery. Anytime you cannulate an artery, you're going to see that on the waveform. Okay? All right. Here's your systole, and here's your diastole. Conditions that elevate PAP pressure. Okay? Non-cardiogenic pulmonary edema. So pulmonary edema coming from this side here. You got volume coming this way into the lungs, but it's not going through the lungs fast enough. So the lungs are flooded with fluid. Okay? So non-cardiogenic pulmonary edema, that will cause it to go up. Alveolar hypoxia, yeah. Like I said, oxygen is a vasodilator, so if you have hypoxemia, then the normal response is that the pulmonary vessels will constrict, therefore increasing resistance and pressure. Okay? Pulmonary hypertension, yeah, right here, something's causing the pressure to be greater than 25/10. COPD does that. Now, COPD, end-stage COPD, and pulmonary hypertension coexist because COPD patients have chronic hypoxemia. So their pulmonary vessels are always, to some extent, constricted. Okay? So if you have end-stage COPD, more than likely you have pulmonary hypertension. Okay? And that's how come we always have to give them like 1 or 2 liters of oxygen to wear, because it helps to dilate their pulmonary vasculature. Hey, she finally made it.
Just hung out.
Where was the wreck at?
Right in front of Chris. And then there was a wreck like behind me. And then I was gonna exit off Gibson, and there was a wreck on Gibson. And then he was crazy.
Forget about that.
Albuquerque is a sketchy place.
Sure.
I don't know where they got their driver's license.
Yeah, I know. I don't know.
They got it from
That's where I
Albuquerque,
stayed
that's
with
why.
Yeah, but I-40
So scary.
coming this way almost every day. I'm like, where did these people get their license? You know?
I watched a girl rear end these people right there at the exit, like when you go to the isotopes part. I don't know what exit it is. But I was gonna get off right there, and I looked up, and she wasn't paying attention. I'm like, what an idiot. I hope she got hurt.
And I heard when that happens to me, if that happens to me when I'm hungry, I'm always very angry. I don't like that to happen to me. I gotta get me something to eat. All right, so now let's keep on going here. I can catch you up later, okay?
Okay.
Alveolar overdistension. Alveolar overdistension, that's very important. You know, like when you overdistend the lungs, okay, compliance falls. If lung compliance falls, oxygen saturation falls. Okay? So that's one thing about adding PEEP, for instance. You add PEEP, compliance improves, oxygenation improves. But once you give too much PEEP, you overdistend the lungs, and then compliance falls and oxygenation falls with it. So if the oxygenation falls, that's constriction of the pulmonary vasculature. Okay? That's increasing resistance. And then it makes it very difficult for the right ventricle to pump, okay, because of the resistance in the pulmonary system. Therefore, the pressure in here goes up. Okay? Cardiogenic pulmonary edema, that's CHF. Cardiac-induced pulmonary edema. So with that, what is going on is that the left heart is very weak. It can't pump all the blood into the aorta, so it backs up into the left atrium, backs up into the pulmonary vein, backs up into the lungs. And so that's cardiac-induced pulmonary edema. Like I said now, the way to distinguish between cardiac-induced pulmonary edema and non-cardiac-induced pulmonary edema is to look at your wedge pressure. Remember what we said about the wedge pressure. Any problem on the left heart will reflect on the wedge pressure. Okay, so if you have cardiac-induced pulmonary edema, that's CHF. CHF is on the left side. Therefore, your wedge pressure will be high. But if you have non-cardiac pulmonary edema, your wedge pressure will be normal because it's not on the left side. It's just right there in the lungs. You haven't started going to the left side yet. Okay? And then we have pulmonary embolism. The same thing. When you have pulmonary embolism, you have hypoxemia. And then you have hyperventilation as a result of that. Okay? So your pulmonary vasculature will constrict. Okay? It will constrict and then increases the pressure. That pressure backs all the way up into the pulmonary artery. Okay? And then causes the pressure to go up. Septic shock. Well, sepsis is infection that has gone all over the body. Anytime you have infection, your body demands a lot of oxygen. Infection makes your body to demand a lot of oxygen, which if you don't provide to the patient, then they will have severe hypoxemia. And then we're back to that constriction of the pulmonary blood vessels. Arrhythmias. Well, arrhythmias is abnormal heartbeat. Abnormal heartbeat. So you know the way the electrical current comes down from the AC node to the AB node to the His bundle, right and left bundle branches, and finally to the Purkinje fibers. That is the normal way for electrical signal to come down. Any other electrical signal that is not coming in that pattern causes abnormal heartbeats. Okay. Now, if you have abnormal heartbeat, that's abnormal contraction. For the chambers to contract more effectively, the electrical current has to come down that way. Because, the Purkinje fibers, is like this around the ventricles. So the entire ventricle would depolarize at the same time, giving it more contractile force. Now, if you have PVC, premature ventricular contractions, the electrical current is originating inside the ventricle. Because it's originating there, it takes a longer time for the current to go from cell to cell, from cell to cell. That's why you have that bizarre QRS. Like that. That's what causes that. See the time here and see the time here. Because that electrical current is originating inside the ventricle, it takes time for it to move around the heart from cell to cell, from cell to cell. So it's abnormal heartbeat that will result in abnormal cardiac output. So if you are having PVCs and you're not being treated for it, you will have a low blood pressure. Okay? Then volume overload. Volume overload, you got too much volume, that will make your right arterial pressure, your pulmonary arterial pressure to go up. Okay, causes of decreased PAP. Well, hypovolemia is another thing. If I return the 5 liters of blood in here, the same 5 liters of blood will go in here, go to the lungs, come around, and get pumped out. What you return to the right heart is what you pump out from the left heart. So, under normal conditions, right ventricular output should be equal to left ventricular output. Under normal conditions, unless you have problems with your left heart. Okay? So hypovolemia will cause PAP pressure to go up because you don't have enough volume inside the pulmonary system. And then the last one is the wedge pressure, pulmonary capillary wedge pressure. We call it that because it is the pressure measured as blood is flowing through the pulmonary vein towards the left side. Okay, it's now leaving the lungs, going towards the left side. So that's what we call pulmonary capillary wedge pressure. Okay? Normal is 4 to 12. It is the pressure that we use to monitor the function of the left heart. Okay? A patient had their mitral valve replacement done, they're back in the ICU. Which of the following pressures would you monitor? Most important to monitor. Well, the mitral valve is on the left side, so we're going to monitor the wedge pressure. Okay? It reflects a preload of the left heart. So therefore, they say, well, how would you monitor the preload of the left heart? You say wedge pressure. How would you monitor left heart filling pressure? Wedge. Okay? How would you monitor left heart end diastolic pressure? Wedge. Anything left is wedge. Anything wedge is left. Okay? Measured from the distal port of the Swan-Ganz catheter intermittently by inflating the balloon. Okay? Like I said, now the catheter doesn't go all the way to the left side. It stops in the pulmonary artery. But what we're going to do in order to measure the left-sided pressure is to blow it out. So we can block the blood flow that is behind it, and then we measure the pressure that is coming from the other side. In patients with no significant pulmonary vascular disease, wedge pressure approximates PAP diastolic. I think I said that yesterday. It approximates left atrial pressure. It approximates left ventricular end diastolic pressure. Now this is what that means. Remember now, the Swan-Ganz catheter has 72 inflation lifetime. So after you have inflated and deflated for 72 times, there is increased tendency for it to rupture. It becomes weak. Okay? So we always try not to exceed that 72, and what we can do, not to inflate it sometimes, is to look at the PAP diastolic pressure. I can say, well, my PAP diastolic pressure is 5. Well, that means that my wedge pressure is 5. If it is 10, that means, well, my wedge pressure is about 10. So we look at that sometimes instead of, inflating the balloon all the time to get the wedge pressure. And then left atrial pressure, that is true, right here. The blood is going from the pulmonary vein towards here. So wherever pressure is here, will approximate that. And then you have your left ventricular end diastolic pressure. At the end of left ventricular, at the end of diastole, okay, at the end of diastole on the left side, before contraction begins, this valve is open. It hasn't closed. The valve will close only when contraction begins. So immediately the end of diastole, this is still open. The pressure here is equal to the pressure here. It's equal to the pressure in the pulmonary vein because it hasn't closed yet. Just like on the right side, at the end of diastole, the pressure here is equal to the pressure here and equal to the pressure here. So if you ask me how would I monitor the function of the right heart, I can go CVP. If you don't give me CVP, I can go right atrial pressure. Or I can go right ventricular end diastolic pressure. The same thing on the left side. I can go left atrial pressure, okay, wedge pressure, or left ventricular end diastolic pressure. Okay? Any questions about that?
How do you get end diastolic?
Huh?
How do you get end diastolic? Because I'm assuming that's different from systemic diastolic. That's a much higher number.
At the end of diastole, they measure, like in the cath lab, at the end of diastole, they measure the pressure inside the ventricle.
So it has to be. I'm assuming then that would also be like an invasive.
Yeah,
like you
it's
can't get
invasive,
that
yeah.
off a cuff.
Yeah, it's invasive. Yeah, it's not something that you use like a sound monitor to do.
Okay.
It's very invasive, you know. What do they call them? Cardiologists. Okay, will do that. Okay. Have you ever heard about angioplasty? Yeah, angioplasty. You know, before that, they're going to make sure you have blood pressures, because what they're going to do is they put that catheter there, and then when they get to where the plaque is, they will inflate the balloon and take off it, and you're trying to move the plaque away from blood flow. Okay? Very dangerous procedure. Very dangerous procedure. Now, I know that you must also have heard about the stents. So they put the stents so that the thing doesn't collapse back in. You know, you have way for blood to go through it. I call it bridge. You know, like you have a bridge. Okay, the fat is on the outside of the stent, and then the blood can go through it. All right. Determinants of waist pressure. Things that can affect the waist pressure. Microvalve function. Yeah, microvalve is right here. If it's not working well, it affects your waist pressure. Left heart feeling. Yeah, if the left heart feels really well, then you have good waist pressure or even high pressure. If it doesn't feel well, then you have low pressure. We'll call that preload. The amount of volume inside the chamber prior to contraction. Left heart function. Yeah, if the left heart function is good, you have normal waist pressure. If it is not good, then you don't have normal waist pressure. Okay. Blood volume. Yeah, the more volume that you have there, the higher the pressure, the less volume, the lower the pressure. Causes of increase in waist pressure. Left ventricular dysfunction. That is true. The left ventricle is weak. Okay? You got blood building up there that is not being moved forward. The volume creates higher pressure. Hypervolemia. Oh yeah, you have too much volume. Okay? It's building a lot of pressure. Anytime the waist pressure is greater than 15 to 18, you have pulmonary congestion. Pulmonary congestion. Okay? If the waist pressure is greater than 25 to 30, you have pulmonary edema. Pulmonary edema. So that means that things are backing up. Begins to back up into the pulmonary system. Causes of decreased waist pressure. Low left ventricular filling. Oh, well, that makes sense because I don't have enough volume in there, therefore the pressure will be low. Hypovolemia. Well, that's true. I don't have enough intravascular volume. Sepsis. Yeah, that causes hypoxemia. Okay. If you have infection, your oxygen goes down. Okay. If you don't give the patient adequate oxygen, then you have other reactions like they become tachycardic. Blood pressure goes up and stuff. Okay. Pulmonary disease. Oh yeah, constriction inside the pulmonary system. Okay. That prevents blood coming from here to go through the lungs to get to the left side. So you have a decreased volume on the left side. Okay? Okay, now let's do this and then we'll go on break. Okay? Now, these two here are called afterload. Resistance. Resistance on the right side is called PV or pulmonary vascular resistance. resistance on the left side is called systemic vascular resistance. I'm going to define it again. I know that I have defined it before. PVR is the amount of resistance that the right ventricle has to work against in order to inject blood into the pulmonary artery. Because the pulmonary artery is the immediate structure that blood goes into once it leaves the right ventricle, most of the resistance on the right side is contributed by the pulmonary artery. The status of the pulmonary artery. If this is constricted, PVR goes up. If it's well dilated, PVR goes down. Okay? So that is the immediate structure. So that gives more of the resistance on the left side, on the right side. Okay? And then SVR is the resistance that the left heart has to overcome in order to inject blood into the aorta. And because the aorta is the immediate structure that the blood goes into once it leaves the left heart, most of the resistance on the left side is contributed by the aorta. If you have constriction in there, that makes it bad. Okay? All right. So what we are measuring with the PVR is resistance to blood flow from here to here. Okay? Resistance to blood flow. See, the distance is not much from here to here. That's what we're measuring. What is the resistance to blood flow? Okay, so if you look at the formula now, it goes PAP, because this is the right side now. So we're going to take average of the PAP pressure, because the blood is going to go in here, goes from here to here. Once the blood comes in here, we calculate the average pressure in here, which is our PAP. And then it ends here to the left side, which is your wedge pressure. And then the flow is cardiac output. Remember how we measure the resistance for mechanical ventilation? It's PAP minus plateau divided by flow, right? That is the general formula for any resistance, including Dr. O's resistance, right? Okay, so that's what we're doing here. So see the cardiac output as the flow. See this one here as your PAP, and then you see this one here as your plateau. So pressure here, beginning pressure here, minus the ending pressure, divided by the flow through there. Okay. Well, the PAP is in millimeter of mercury. That's the unit there. The wedge pressure is also in millimeter of mercury. The cardiac output is in liters per minute. So we have to convert those two different formula to one formula. So what we do is we multiply by 80. Okay? So now it will be like, if you calculate the PVR, what you're going to have is a millimeter of mercury per liter per minute. If you don't multiply it by 80, millimeter of mercury per liter per minute. But now when we times by 80, we'll convert it to a unit called the things. That's why we're multiplying by 80. So that 80 is a constant number. Okay. So on the exam, if they have the answer in millimeter of mercury per liter per minute, you don't have to multiply by 80. Well, if they give you the answer in dens, well, it means you're going to multiply whatever you get by 80. Okay? Any questions about that? Well, let's do normal plus normal equals normal. Normal plus normal equals normal. That formula. I love that formula. What's normal impact? How would you figure out normal MPAP? We're gonna do, what's normal PAP pressure? What's normal PAP pressure? 25 over 10, right? So you will systolic plus 2 times diastolic divided by 3. Well, 25 plus 10 divided by 3, that gives me 15. So I can put my 15 here. Minus breast pressure, my God, 4 to 12, right? Well, I'm just going to pick 8. Divided, what's normal cardiac output?
4 to 8,
Yeah,
so 6.
so let's do the middle, 5. So I have 15 minus 8 will be 7, right? And 7 divided by 5 will be 1.2. Is that correct?
4. 1.4.
Okay, thank you. 1.4 millimeter of mercury per liter per second. But if I want to convert that to gains, then I multiply by 80. So multiply by 80, what you got?
Got rid of my calculator.
I said multiply by 80. She just smiles.
112.
Well, you go ahead and do it. Huh? What you
That feels
got?
low. 112.
112, okay.
Why is that low?
112 means is our answer. Okay, so that would be what we call normal PVR. Now, but on the test, okay, what we use is 150 to 350.
Is that just-
150 to 359 is normal PVR. Okay?
Is that just because it's easier to remember than 112?
Huh? No, not remember the 112. You know, I mean, like I said, everybody cannot always be in the same range. But 150 to 350, in fact, on the MBOC test, when they say 200, they kind of average it out. 200 is what they call normal. Like I said, I mean, don't be very rigid, you know? All right.
What's a good range then? Because if 112 is normal,
Huh?
if 112 is normal, where should I start my range of
Yeah.
normal?
Now, let me tell you another thing with MBOC, okay? Now, I told you now 150, okay? Let's say that if they go, well, what's normal PVR? And 112 is given, and then the next one is 300, the next one is 350, the next one, no, well, let me go, 112, okay? So the next one is 500, the next one is 550, the next one is 600. Which one would you pick? Yeah, and that's what they do on the exam. They realize that everybody is reading different textbook. Okay, now if you look in your textbooks, the numbers are different depending on what you're reading, which test you're reading. So that's why they space it out so much that even if somebody is an idiot, they will know. Okay, because they will know why it's very close to that. Right? Yeah, you will know. So that's the way they do it on exam, okay? I'm not calling you an idiot. I love you, okay? That's not what I'm saying. I don't want you to go out there and say, oh, Dr. O said that I'm an idiot. No, I'm not doing that. All right, so any questions about that? Okay. Now, let's go to SVR, okay? So with the SVR, we're measuring the resistance from here all the way to here. resistance to blood flow from here all the way to here, okay? So if you look at the formula then, here's your map, mean arterial pressure. Once the blood pumps out in here, we calculate the mean, and then it begins to flow, goes all over the body, and then comes back here to the right side, which is your CVP. So the formula for that is mean arterial pressure minus CVP divided by cardiac output. Then times 80 if you want to convert it to Danes. The normal over there is 800 to 1600 Danes. Okay? Well, the longer the distance, the more the resistance. Just like the ET tube, if you intubated your patient with endotracheal tube and then you have another patient with tracheostomy tube, the patient with the ET tube would have more airway resistance compared to somebody who has tracheostomy tube. The shorter the airway, the less resistance. The same thing here. So we have a longer distance for the blood to flow. Therefore, the resistance will be more on the left side. Okay? Now, let's see how we can fix this now. We say that, let's say that normal, the highest normal for the PVR is 350, right? Assuming that a patient's PVR is 500, what does that mean to you? What does that mean? It's 500, right? I have more than normal resistance in the pulmonary system, right? What kind of drug would I give to lower resistance?
Oxygen.
Huh?
Oxygen.
Oxygen, yeah, oxygen would do it. Oxygen is a vasodilator. Yeah, oxygen would do it. But what else?
I can never remember.
How
the name of
about
it.
nitric oxide?
That's right.
Nitric oxide. It's a pulmonary vasodilator. How about Viagra? That's pulmonary vasodilator. How about Cialis? I can keep on going on and on with that. And so those kind of drugs will lower pulmonary vascular resistance. Okay? Then on the left side, I have resistance that is 2,000, where normal is supposed to be 800 to 1600. But I have resistance that is 2,000. What kind of drug would I give? So I need a systemic vasodilator. Okay, systemic vasodilator. So what I'm going to do is like drugs like nitroglycerin. Nitroglycerin, and it's a systemic vasodilator. Okay, we have nitro proside sodium. Okay, this one here on the exam they call it nitride. It's a systemic vasodilator, or you can do isodil. They call it isosobid. Then the treatment for that is isobid. And this medication was derived from nitroglycerin. So it's actually a brand of nitroglycerin. So those are systemic vasodilators. So when your resistance is very high, on the left side, you give systemic vasodilator like nitroglycerin, nitroprusside sodium, isosobate, the nitrate. when your resistance is high on the right side, you give oxygen, nitric oxide, those other drugs like Viagra. Okay? Any questions? What else did I want to say about this? Okay, so that's it. Oh yeah. On the left side, supposing that they ask more about the left side of this one here, that I have SVR that is 300 limit of mercury. Is that enough?
No.
That's below normal. So that means that my vessel is dilated. So this is my normal, the normal diameter of my blood vessel, and then this is like this. So my blood vessel is like that. It's dilated. So when your blood vessel is over dilated, your blood pressure will go down. Your blood pressure will go down. So how do I fix this? Well, I need to give a drug that will cause it to go back like that, or even like that. So that's what we call pressors, vasopressors, like epinephrine, vasopressin, dobutamine, dopamine. So those are pressors. They will constrict the blood vessels and increase your blood pressure. Okay? All right, so I think it's, I gave you an example. So we've already done this. So look over there. Here's your SVR. Review time, define PVR, done that. Name two things that can cause wedge pressure to increase. Actually, mechanical ventilation can cause it to go up. The higher your PAP, especially with PEEP, okay, the higher the wedge pressure, because positive pressure causes cardiac output to decrease. Okay? Name two conditions that will cause the wedge pressure to decrease. Hypovolemia. Okay. Mitral valve insufficiency. Okay. What else? What else did we say? My brain just went blank. Huh?
Shock.
Yeah, shock. Yeah, very good. Name two conditions that will cause PAP pressure to increase. Pulmonary embolism, pulmonary hypertension, hypervolemia, all of that. Any kind of problem inside the pulmonary system. What is normal wedge pressure? 4 to 12. All right, so we're going to take our break now. When we come back,